Hello, everyone, and thank you for being here today. My name is Tanya Hyde, and I'm with the Canadian Institute for the Relief of Pain and Disability. And you're here for the Working Beyond Cancer, What We Do and Don't Know webinar. Glad to have you here with us today. This webinar is part of our Return to Work, Stay at Work series. This webinar is made possible through the support of the Community Grants program through the BC government, as well as through donations and memberships. As I mentioned, my name is Tanya, and I'll be moderating the session today and handling the Q&A as well. And our speaker is Dr. Saskia Duijts. Saskia completed her PhD in occupational epidemiology in 2007, after which she worked as a postdoc at the Netherlands Cancer Institute in psychosocial oncology. In 2010, she started as a senior researcher at the VU University Medical Center, combining both subjects, i.e. cancer and work, and nowadays she is supervising PhD students in this research area. In 2014, Saskia received a 4-year fellowship from the Dutch Cancer Society to expand her research on cancer and work. And now I will hand it over to you, Saskia.
Okay, thank you, Tonya. Thank you for the introduction. And first, I would like to welcome everyone who registered for the webinar. I think I have to say good morning to those who are joining us in Canada and the US, and good afternoon to those in Europe, and maybe even good evening to those who are joining us in Asia. Thank you for the invitation. Thank you, the Canadian Institute for the Relief of Pain and Disability, for inviting me to give this webinar on my main research topic, which is cancer and work. And as Tonya mentioned, the title of this specific webinar is Working Beyond Cancer, What We Do and Don't Know. So, as said, my name is Saskia Duijts, and I will start with giving a bit of background information on who I am. So, I'm a senior researcher at the VU University Medical Center. You can see a picture of the VU in the left side of the slide, and also at the Netherlands Cancer Institute, both located in Amsterdam, and you can see a picture of the Netherlands Cancer Institute on the right side of this slide. I'm also a fellow of the Dutch Cancer Society, and I will be talking about my fellowship later on in this webinar, but just to give you a bit of an idea, the Dutch Cancer Society assigned fellowships until this year because they stopped doing it, unfortunately. But they assigned fellowships on clinical, fundamental, translational, and psycho-oncological research. And I applied for a fellowship in 2013, and it was approved, and I started with the fellowship next to my work as a senior researcher in 2014. So, with regards to my background, I'm an epidemiologist, and I did my PhD in occupational health epidemiology, and I completed it in 2007. And we did a project aimed at identifying employees at risk for sickness absence due to psychosocial health complaints. So it was quite a big national project. We developed a screening instrument, and thousands of people completed the screening instrument, and everyone who scored above a certain cutoff point was invited to participate in a randomized controlled trial. Those who were in the intervention group received a preventive coaching intervention, and those in the control group just care as usual. And we looked at things like sickness absence at follow-up 6 months and 12 months after the start of the project. So it was quite a big project in occupational health epidemiology, and after it I changed from occupational health epidemiology to cancer epidemiology, and more specifically psychosocial oncology. So I started working at the Netherlands Cancer Institute in 2010 as a postdoc, and at this institute my main task was to evaluate the effectiveness of a physical exercise and cognitive behavioral therapy program in breast cancer patients experiencing acute menopausal symptoms due to treatment. So this is quite a mouthful. We were only including breast cancer patients below the age of 50 because they can become acute menopausal because of their treatments, chemotherapy or hormonal treatments. And it's quite different from someone who is in natural menopause because it's just really acute from one day to another. They enter menopause. And the problem they have is that they are not allowed to take hormone replacement therapy because this can increase tumor growth again. So that's quite dangerous for breast cancer patients. So at that time we were looking at more alternative options. And we knew already that in women entering natural menopause that things like physical exercise and cognitive behavior therapy might work. And regarding physical exercise, when someone has menopausal complaints, you have to think about hot flashes and night sweats, and intense physical exercise might regulate the thermoregulation of the body. So that was the idea behind physical exercise. And with regard to cognitive behavioral therapy, it's more about coping with the menopausal symptoms and menopausal complaints. So I participated quite a lot in the cognitive behavioral therapy groups during that project. And while listening to all the women participating in those groups, they were not only talking about menopausal complaints, but they were talking about a lot of other things. And one of those things was work-related problems, going back to work, being at work and experiencing problems at work, those kind of things. So for me at that time, it was like two things coming together. My PhD project, which was about work, occupational health, and the study population in which I was really interested, cancer patients. So from that moment on, I decided to combine both subjects, and I started as a senior researcher in 2010 at the University Medical Center in Amsterdam, combining those two subjects. And as said, I also started with the fellowship, which is completely on cancer and work, in 2014. So to give you a full picture about my background, I'm also involved in the Dutch Association for Psychosocial Oncology. It's the NVPO. For about 6 years now, I'm the editor-in-chief of the journal Psychosocial Oncology. It's also my last year because I'm going to hand it over to a successor. And I'm also a board member in the society and a member of several committees of the association. And since a few months now, I started as the associate editor of the European Journal of Cancer Care. So changed from a national journal to an international journal, which is really nice. It's a really good experience in the first few months. So I think this is quite enough about who I am and my background. So I will proceed with the content of this webinar. I'm going to start with a part on what we do know about cancer and work research. So I will start with a short history of cancer and work research. First, I'm going to talk about occupational cancer, then the shift towards occupational rehabilitation in cancer patients and survivors, and cancer and work research from 2000 until present. The second part within this part, what we do know, is about current facts and figures on cancer and work, factors that facilitate or inhibit return to work, and also interventions to support patients and survivors to return to work. Then in the second part of this webinar, I'm going to talk about things that we don't know yet related to cancer and work research. So I'm going to ask the question if return to work can be seen as behavior, and if so, if behavioral change models can be applied here to understand return to work. And I will complete this webinar and end with a part on things that you must not forget. And I'm going to talk about problems beyond return to work, so in those who are occupationally active again, and coping with diagnosis and treatment at work, so after the return to work. So as Tonya said, I think there's quite a lot of time for Q&A, question and answers at the end of the webinar, but there are some moments during the webinar that I will stop for a moment, and if there are clarification questions or something, then please ask. So things that we do know, the short history of cancer and work research. Well, it all started with research into occupational cancer. Globally, about 19% of all cancers are attributable to the environment, including work. And there are all kinds of exposure situations which are carcinogenic to humans. You can think about biological carcinogens like a virus known to cause cancer, or chemical carcinogens like asbestos at the workplace, or physical carcinogens like UV radiations. And there was quite a list of cancers that are associated with occupational exposure. And this is just a small selection, but you can think about things like bladder cancer, which can be caused by exposure to arsenic, or bone cancer, which can be caused by exposure to ionizing radiation. The same goes also for brain cancer. Leukemia can be caused by exposure to benzene, and lung cancer to asbestos, nasal cancer to chromium, and so on, because the list is much longer than this. When we look at occupational cancer, and specifically occupational cancer research, I did a short search and we found already studies in the 1950s of the last century. And then you can think about things like lung cancer in chromate workers, an article in 51. In 55, an article about urinary bladder cancer in asbestos textile workers and iron ore miners. In 76, metamaterial workers and lung cancer, and a bit more recent, well, it's about 20 years ago already, in 94, looking back a certain amount of time, cancer mortality patterns among female and male workers in the cable manufacturing plant, World War II. So there are many articles already on occupational cancer in the last century, so this is also just a small list. But when we look back in cancer and work research, it all started with research into occupational cancer. That doesn't mean that occupational cancer isn't important at this moment, because, and this is just to give you an example, in the last few months, years, there's quite something going on in the Netherlands, because there's quite a high incidence of cancer in previous workers or former employees who worked for the Ministry of Defense here in the Netherlands. It turned out that they have been exposed to chromium while working, and this happened while they were working on army trucks, while they were painting army trucks. So even now in 2015, even in the Western world, research into occupational cancer is really important. However, about 40 years ago, we also see a shift towards occupational rehabilitation of cancer patients and survivors. So as said, it is a topic of interest for about 40 years now, and this corresponds a bit with the beginnings of the subfield psycho-oncology, the subspecialty of oncology, because that started in the 1970s, in mid-1970s. And this had to do with two stigmas that diminished around that time. So the first one was that it was really hard for people around that time to speak about the diagnosis of cancer. And around the mid-70s, we see that that physicians and patients became more able to speak about their diagnosis. And the second stigma was that there was quite a negative attitude towards psychological problems. So also talking about psychological problems was quite a difficult thing to do. So about 40 years ago, both stigmas diminished, and then we see that next to all the big epidemiological studies on occupational cancer, also the first studies on things like return to work, occupational rehabilitation after cancer became more and more important. So looking at occupational rehabilitation of cancer patient survivors and the research related to this topic, we see a remarkable change in tone and issues within this area of research, because early research reported only on things like job discrimination of cancer patients. There was a groundbreaking study, for example, in the 1970s by Professor Dr. Feldman, and also other difficulties like insurance problems, health insurance problems, life insurance problems, and also lack of understanding from co-workers was a topic. And this was already described by Borowski in 1989 in the book Work and Illness to Cancer Patients. So it started with job discrimination and insurance problems, but in the following years we see that a much broader scope of factors became involved in the research related to occupational rehabilitation of cancer patients and survivors. So in 2002, Spelten et al., she published their literature review on factors related to return to work of cancer patients, and she included 14 studies, and they were all between 85 and 99, and she investigated 41 factors in those studies for the association with return to work. She included 10 work-related factors, and then you can think about the attitude of co-workers, physical demands, changes in tasks at work. Also 10 disease or treatment-related factors were included, and then you can think about cancer stage, cancer site. And 21 person-related factors were included, and then you can think about things like social demographics, health, psychological complaints. So apart from the specific results of this literature review, the point I would like to make here is that it all started with things like job discrimination and insurance problems, but in the following years you see that a much broader scope of factors became involved in the whole research area around occupational rehabilitation. So looking specifically at cancer and work research, and here with cancer and work research, I specifically mean occupational rehabilitation. So I'm not talking anymore about occupational cancer. But looking specifically at this research from 2000 until present, we see that there was an increase in the number of studies published each year. So in 2000 it was about 30, then there was a small decline and afterwards goes up again until about 60 each year of studies being published on cancer and work. And when we look specifically at these studies, we see that they have been described from different perspectives. And the main important one, of the most important one, is the perspective of the patient or the survivor. It's also the perspective that has been described most frequently. So then you can think about that projects have been done on workability of the survivors or on job satisfaction, for example. But also there are studies related to the caregiver or the family, and then you can think about that it can be quite a burden for a family member to take care of someone with cancer, and it also might affect his or her own job, or maybe it can lead to financial problems. There are quite some studies related to the employer and co-workers. For example, co-workers might experience an increase in workload because they have to take over tasks from someone who is on sick leave. It's not specifically related to cancer, but it is something that we've seen in research on cancer and work. And also other perspectives are, for example, from the perspective of the healthcare providers or the community or the society. So things that have been investigated quite a lot in the last years from 2000 until 2015 are factors promoting or hindering return to work and work performance. And also there are quite some intervention studies and programs focusing on psychological, physical or multidisciplinary approaches to return to work in cancer patients and survivors. So to complete this first part, looking back, it's everything that I've talked about, starting with occupational cancer, it can a bit be related to Maslow's pyramid, because if you look at the pyramid and you look at the very bottom of the pyramid, it's all about things like physiological things, safety kind of things. So it started with occupational cancer only to go up into the pyramid to things like belonging at the workplace, the attitude of co-workers. And now we see that research in the last year is much more about things like self-esteem, self-actualization, fulfillment through work, identity that people are developing through their work. So looking back at this short history of cancer and work research, as said, it all started with occupational cancer. We have already seen studies in the 1950s of the last century. In the 70s, occupational rehabilitation and psycho-oncology became more apparent, and also the first studies in occupational rehabilitation started, first on job discrimination and insurance problems, and in the 80s and the 90s we see a much broader scope of factors being involved. And in the last few slides I was talking about the research from 2000 until present with all the different topics and the different perspectives. So to complete this first part, are there any questions or any clarification questions at this moment?
All right, we'll just give people a couple of seconds here to type. There's nothing yet, so.
Okay, so I can also proceed with the second part, which is about current facts and figures on cancer and work. So we know that there are 3.5 million new cancer cases each year in Europe. This is specifically for Europe. 50% of them is diagnosed when they are at working age, so that's quite a lot. And if I look at the numbers in the Netherlands, we have about 100,000 new cancer cases each year, and about 40% of them is diagnosed at working age. So it is quite an important topic to look at. And we know that return to work is very important for both the individual and the society. related to the individual, return to work can increase self-esteem, it can increase self-worth. I also was talking about that in the top of the pyramids of Maslow in the former slide. It can give people back a sense of normalcy. They think, okay, if I'm going back to work, I'm not a patient anymore, I'm an employee again. It may lead to new social relationships, and it might provide, also quite important, financial security. For the society, it's also quite important that people contribute to the society. And it's also a cost-relating thing because it might reduce work incapacity. So return to work is quite important for both the individual and the society. We know that at 6 months after diagnosis, and this is specifically for cancer patient survivors, 40% was able to return to work. And these are international numbers. At 12 months after diagnosis, the number is 62%. At 18 months, it's 73%, and at 24 months after diagnosis, it's 89%. So this is quite a positive trend. And we also know, looking at longer follow-up, so 5 years after diagnosis, that the percentage is decreasing again, stabilizing a bit around 2/3 of the patients being able to go back to work. So these numbers are international, but they also could be applied to the Netherlands, because we in the Netherlands have a system that after 2 years of sick leave, someone will be assessed by an insurance physician. And we see that a lot of people try to return to work before this assessment, because afterwards they will be decided if someone will receive a disability grant, and that's not always the case. So these numbers could also be applied to the Netherlands. So when we look at research into cancer and work, we see that the study population that is quite often involved are breast cancer patients. We also see some studies with mixed populations, for example, breast cancer and gynecological cancers. And in some studies, there is a variety of other tumor entities, such as gastrointestinal cancer, hematological cancer, and urological cancers. Specifically with regard to these type of cancers, we know that after 2 years after a cancer diagnosis, that the highest percentage of patients who had fully returned to work were those who had female genital cancer, male genital cancer, skin cancer, or breast cancer. And the lowest percentage of patients who returned to work were those who had lung cancer, head and neck cancer, and gastrointestinal cancer. So, for example, with regard to lung cancer, we know that a lot of the time the prognosis isn't that good, so it's quite difficult for lung cancer patients to return to work. But also with regard to head and neck cancer patients, they will be treated in the facial area, and surgery or radiation might affect things like speech or swallowing, eating. So those are also quite important things for people who want to return to work. Specifically, if you have a certain job in which you have to talk to people quite a lot, then it's quite hard to return to work. The outcome measures used in cancer and work research, well, this is just a small list, but what we see a lot is return to work or time to return to work. Employment status is somewhat at work or not at work. The length of sick leave and risk of unemployment. So with regard to risk of unemployment, we found in previous studies that between 26 and 53% of the cancer survivors lost their job or quit working over a 72-month period post-diagnosis. So a quarter until half of the patients lost their job or quit working within 6 years after diagnosis. So I think it's quite a lot. And also cancer survivors had a significantly increased risk for unemployment, early retirement, and they were less likely to be re-employed. So this is a topic that we know quite a lot about. I mentioned it in the beginning, the factors that facilitate or inhibit return to work. But this is a small overview. So we know that those, and this is quite obvious maybe, that someone who is younger is more likely to return to work than someone who is a bit older. Also, someone who is male, so a man, is more likely to return to work than a female or a woman. those with higher education are more likely to return to work than those with lower education. So this is something about the social demographics. But we also know some factors related to the more physical or disease-related things. So those with less physical symptoms, those with less invasive treatments are all more likely to return to work. Also those with lower length of sick leave, also quite obvious, but those the how longer you are on sick leave, the more difficult it will be to return to work. And related to work, we know that patients who talk about the diagnosis and talk about treatment, so disclosure to colleagues, that it makes it more easy to return to work. Those with flexible working arrangements, this is a little bit related to those with a higher education, but because it's mainly related to autonomy at work, arranging your own work and the tasks you are doing and time that you start working or finish your day at work, and also perceived employer accommodation. So there's quite some research already into factors that are related to return to work, and these are factors that we know by now that are related to return to work in cancer patients and survivors. So one of my PhD students also looked at factors related to return to work. His name is Peter van Meijen. He did a review and he included 28 cohort studies in this review. We found about the same results as mentioned in the former slide. He looked at two different outcome measures, at employment status and at return to work, and we found that older age, female gender, low education and low income were negatively associated with employment status. We also found that heavy work and chemotherapy were negatively, and less invasive surgery was positively associated with return to work. And he also found that breast cancer patients were more likely to return to work. So looking at cancer and work research, and then mainly the occupational rehabilitation part of the cancer and work research, we noticed that these studies are mainly performed in Western countries. It isn't that strange because this all has to do with survivorship rates. And in Western countries, in Europe, in America, in Australia, the survivorship rates of cancer are really going up. And then things like psycho-oncological topics like return to work become more and more important. Well, for example, I think about 2 or 3 weeks ago, a researcher from Singapore contacted me, and Singapore is quite a Western country within Asia. But he contacted me and he was really interested in cancer and work research because he said that the survivorship rates were also quite going up over there, and that he was more and more interested in problems like returning to work and staying at work after cancer. Okay, so I also want to say something about the intervention studies and programs. So up to now, interventions have focused on psychological, physical, or multidisciplinary approaches to influence work outcomes. And just to make a small sidestep, most of the studies are related to employees who have an employment contract. So intervention studies are focused at employees who have an employment contract. So another PhD student of mine, Martine van Egmond, she's doing a randomized controlled trial at the moment, and she is only looking at patients without an employment contract. So we call them social security safety netters. And this is quite a specific group because it's quite difficult for them to return to work because they don't have a job to return to. But it doesn't mean that these people don't want to go back to work, but it's hard for them to go to work because they don't have a job to return to. So we are doing an RCT at the moment and looking at the coaching intervention and placement, actual placement at work. And she just finished her recruitment phase, so I cannot show you any results yet. But the point I would like to make here is that it's not only about those with an employment contract. Return to work is also about those without an employment contract. For example, in the Netherlands, there are still about 600,000, 700,000 people who are unemployed at the moment. So also within that group, there are people who can be diagnosed with cancer and they need support to go back to work again. So back to the interventions. There was a recent review And they looked at all kinds of interventions related to return to work, but they only found 3 interventions which were aimed primarily at enhancing return to work or employment status. So within this review, there were quite some interventions involved. There are quite some studies that they have included. However, a lot of the interventions were, for example, aimed at enhancing quality of life or diminishing fatigue. And there were only 3 that were primarily developed to enhance return to work. So what they also found was of the 4 controlled studies in this review, there was only 1 intervention that increased return to work significantly. So after all these years of research, there was only 1 controlled study in which the intervention increased return to work significantly. So I think that we can say that the evidence for return to work interventions is quite modest at the moment. So this was also the question that I was asking myself while preparing the fellowship application, because I think that we are missing something. We have all these years of research. We know quite a lot about which factors are related to return to work, which factors are not related to return to work. There are quite some interventions developed to support patients to return to work, and only 1 intervention is significant. So only 1 intervention is effective in supporting patients to return to work. So question is, are we missing something, or what is the missing link? So that brings me to the part on what we don't know. So this is also a moment to stop and maybe ask some questions of this first part on what we don't know.
All right, there
Or
are.
what we know, I have to say. Sorry.
We do have 2 questions. One of them, with respect to return to work after 5 years, can you discuss what factors might contribute to the decline from 89% after 2 years to 67% after 5 years?
Okay, yeah, that's a good question. Well, we know that there are quite some both physical and psychosocial problems at long-term follow-up of patients. So a lot of the studies are now looking just at 1 year or two year after diagnosis, but we know that a lot of patients have complaints for years after primary treatment. So things like fatigue, what I was talking about totally in the beginning, menopausal complaints, cognitive functioning. I will be talking about it also later in this webinar. Those are things that are not, they don't stop, the complaints don't diminish after someone returns to work. So we see that these complaints can persist for years, and also when someone tries to return to work, they have to adjust again in the new role. They have been out of work for some time, and we see that even the patients who managed to return to work, sometimes they are on sick leave again after a few years. So because they have some problems finding a new balance, they have to learn to cope with things that they are not able to do anymore, those kind of things. So we don't think it's really strange that the numbers are decreasing again.
All right, and then someone else asked if a person wants to find a job. If a person wants to find a job and has cancer, how much should be revealed during the interview process? So this is for the people who were unemployed when they got diagnosed.
Well, that's really good, but a really difficult thing to decide upon, because that's something that a patient has to decide him or herself. Well, I don't know how it is in other countries, but if I'm going to talk about the Netherlands, someone is not obliged to say something about a medical history. So if you don't have a job and you are going to apply for a new one, you're not obliged to say, okay, but I've had cancer, I've been diagnosed with cancer, I've had treatment. So, but we know, and that's the difficult part of it, that a lot of patients have problems with this whole topic, because they are asking themselves, what do I have to do? Do I have to talk about it or not? Do I have to be open to my new, probably maybe new supervisor about what has happened to me in the last years? And we know that a lot of patients are struggling with that question, because they also think, okay, but if I'm if I'm telling it and there is a chance that they don't give me the job. And a lot of people think, okay, but I just want to be honest about it. But there's not a right answer here. It's something that is very personal, I think.
All right, and then one follow-up question to that. Are people obliged to identify any limitations they have that could affect their ability to do the job? And again, I think you can speak for the Netherlands because obviously that's different country to country.
Yeah, yeah, but it's the same with the diagnosis. They're not obliged to, and a supervisor or an employer they can ask about it, because it's not that that it's forbidden or something to ask about physical limitations. But the patient, it's not obliged to talk about diagnosis or physical limitations. But still, a lot of people think, okay, but I have to say something about it. So it's a really difficult position that they are in.
Yeah. All right. That is all of the questions for now.
Okay. So I'm going to proceed with the part, things that we don't know. Okay, we think that there are, if you are looking at cancer and work research, that there are three parties involved. First, you can look at the work part. So you can look at the type of job. If there is employer support, things I've been talking about before, if there are flexible working arrangements, are there physical demands at work, those kind of things. The second thing is you can look at the disease, cancer in this case. You can look at the type of treatment. You can look at the cancer site, cancer stage, physical limitations someone has as a consequence of treatment. But also there is a third part, you can look at the individual. And I've already talked about some of the socio-demographics. So for example, that a younger person who is male and has a higher education is more likely to return to work than someone who is older, is female, and has a lower education. But this is not the only thing you can look at within the individual, because we know that very little attention is paid so far in research to behavioral determinants of return to work in cancer patients and survivors. So the question here is, can return to work be seen as behavior? Can you look at return to work as something you do or something you don't do? You go back to work or you don't go back to work? Because if you look at return to work as behavior, then all kind of behavior determinants. Okay, something is going on here with my computer. I don't know if you see this. I'm going to, yes, I can skip this. Okay, so if you look at return to work as behavior, then all kind of behavior determinants might be important to consider in cancer and work research. And that hasn't been done so far. So maybe this is well known to everyone, but I just want to go into this theory of planned behavior shortly, because it's quite an influential theory and it also can be applied in this case. So this theory states that people's behavior is best predicted by basically asking people about their intention to display a specific behavior. You can ask them, do you intend to go back to work? So the intention is between some of the determinants and the actual behavior. So intention is influenced by three determinants, and the first one is attitude. So this is the positive or negative evaluation of the expected outcome of a certain behavior. So someone might say, when I return to work, it will give me back a sense of normalcy. So that's maybe quite a positive attitude, which might help someone to actually go back to work. The second one is subjective norm, and this is the belief about what others think of the behavior as derived from the behavior and or direct feedback of significant others. So someone might say, my occupational physician told me to report sick after receiving my diagnosis. So subjective norm is also about social support and social pressure. That's also included in this concept. And it's just specifically about the norm. What is normal to you? If you are in an environment with family, friends, your neighbors, and a lot of people are not working, maybe then you think, okay, but it's quite okay to stay at home for a while. So this is subjective norm. And the third one is self-efficacy. And this is the degree to which an individual believes that the behavior is under his or her control. So someone might say, I'm not able to perform my tasks at work at the moment. So if you think that you're not able to do your job, then probably you don't think, okay, I will go back to work. So these three determinants might influence behavioral intention. It's about the same as motivation, which might lead to the actual behavior, in this case, return to work. So in 2009, Brouwer et al. Explored this association between attitude, subjective norm, and self-efficacy, and time to return to work. And she included 926 employees on sickness absence. They had different reasons for sick leave. There was a group with musculoskeletal symptoms, and there was a group with mental health symptoms, and there was a group with other symptoms. There was no cancer patient involved here. She found that work attitude, social support, and willingness to expend effort in completing the behavior, and social support is related to subjective norm, and willingness to expend effort to complete behaviors related to self-efficacy, that these three determinants were significantly associated with a shorter time to return to work in employees on long-term sickness absence. So she found that there was a relationship between these three determinants and a shorter time to return to work. So we also know that musculoskeletal symptoms and mental health symptoms are not the same as cancer, but it might be a promising approach to address behavior determinants in the development of interventions focusing on return to work in cancer survivors on sick leave, because it hasn't been done before. So next to the behavior determinants, subjective norm, attitudes, self-efficacy, there are also other behavioral determinants, personal factors, which are quite important to consider. For example, the meaning of work. Someone might ask him or herself, what does work mean to me, and how important is it for me at present? Because it might be that the meaning of work has changed for someone. Someone might think before a diagnosis, well, work is really important and it's really meaningful to me, and then someone is diagnosed with cancer and treated for cancer, and the meaning of work, it is possible that it has been changed, and that other life priorities became more important. So the idea is that if someone is physically maybe able to go back to work, and also at work they are supporting this person to go back to work, but if meaning of work has changed for this person, then you can apply all kind of interventions, but probably this person won't go back to work, because you have to take these kind of things into account. Second one is illness perception. And this is related to the theory of illness perception of Leventhal. He developed the theory in the 80s, in 1980s, and he said that if the patient considers the disease as a narrowly defined as medical disorder, as the duration as long, and the consequences as serious, then the functional outcome will be worse, irrespective of the objective medical seriousness of the illness. So, okay, this is quite a mouthful, but he actually said that if you look at your disease as a death sentence, then you will totally have a different perception of going back to work than someone who thinks, okay, this is really severe and I have to take it step by step, but we'll see. So the perception of your illness is quite important to consider. And also coping strategies. So someone with a more active or problem-solving coping strategy might say, I will actively try to return to work, and this might help someone to return to work. So it's not only about behavior determinants like presented in the model and in theory of planned behavior, but also other factors are important to include when developing interventions for return to work in cancer patient survivors. So we tried to look at all these theories and models used in cancer and work research, but when we look at the triangle cancer, work, and behavior, there are no studies taking all these three concepts into account. So we looked at two different parts, and we did that in a systematic review. It's almost finished to be submitted to a journal. The first part is that we looked at all kind of theories and models used in behavioral research in cancer patient survivors. So this is the behavior and cancer part. So you can think about all kind of different behaviors, because there's quite some research going on related to increase of exercise in cancer patients, change of diet in cancer patients, stop smoking, diminish alcohol use, those kind of things. And also there are quite some theories and models used for the development of interventions related to, for example, increase exercise in cancer patients and survivors. So we made an overview of all kinds of studies using these theories successfully to develop interventions for these patients. The second part is that we looked at the behavior and work part. So we looked at all kinds of behavior determinants related to return to work. There's hardly any study in cancer patient survivors, but we found quite some studies in other diagnosed groups. So, for example, musculoskeletal symptoms or patients with mental health problems. So with these two parts, we had a whole overview of both cancer and behavior research and behavior and work research. And the idea is, with the overview, can we combine these parts and say something about that triangle, cancer, work and behavior, and to get an idea of is it possible to use behavior determinants in the development of interventions for return to work in cancer patient survivors. So we hope to publish this systematic review in short time. I hope so. One of the models that we found in this review quite often was the trans-theoretical model, and this is quite interesting. It's a stage of change model from Prochaska and Di Clemente, and this model exists of 6 stages. So when you apply these stages to return to work, then you can say that the first stage, that's pre-contemplation. If someone is in pre-contemplation, then this person is not considering returning to work within the next 6 months. If someone is in contemplation, then this person is considering to return to work in the next 6 months. In preparation, someone is beginning to take active steps to return to work. In the action phase, someone is back at work. Maintenance, someone is staying at work for 6 months or more already, and in relapse, someone is on sick leave again. So the idea behind applying such a model is that someone who is in pre-contemplation phase, for example, needs a totally different intervention than someone who is in maintenance and needs an intervention to prevent future sickness absence, for example. So the whole question is, can these models and theories be applied in return to work research in cancer patients? So to get an idea about that triangle, cancer, work and behavior, we also did an interview study in the first 3, 4 months of this year. I performed 28 interviews with cancer patient survivors on the role of behavior determinants in the return to work and continuation of work. We looked at both return to work and continuation of work, because there were still some patients on sick leave trying to return to work, and there were also some patients who already returned to work, and their objective or their aim was to stay at work and to continue their work. So we included breast cancer patients, colorectal cancer patients, and head and neck cancer patients, and they were all between 1 to 2 years after diagnosis. They all had an employment contract at the time of diagnosis, and I asked questions, and this is just this is a small list of the whole questionnaire about the meaning of work, the change in meaning of work after diagnosis, their attitude towards work. Is it positive or negative? Did they receive social support? Did they receive social pressure to go back to work? And also we talked about expectations they had immediately after the diagnosis about their return to work, or if back at work, about the continuation of work. Did they expect to be at work again or to stay at work? So we are in the middle of the data processing at the moment, but I have some quotes from these interviews. So for example, a male participant, he was telling something about that expectation, and he said, I always expected to return to work, even in the beginning, just after diagnosis. Yes, I was scared, but I had no doubt being able to work again. So we are interested in the fact if something like this, having a positive expectation about returning to work, is actually helping in return to work after diagnosis. A female participant said something about social pressure, and she said there was quite some social pressure around me saying not to go to work, to take it easy for a while. But because of circumstances at work, and in this case it was a reorganization, I was not sure if that was the best advice. So this woman actually returned to work quite early. So this is also a work-related thing, because a reorganization at work was going on, but she was also quite quite a long time she was talking about the social pressure she experienced from also from her family and friends not to go to work and how to deal with that. So looking back at the things that we don't know, we began with a lot of things that we do know about the factors related to return to work and all the interventions that have been developed, and also that there is only one intervention so far showing an effect on return to work in cancer patient survivors. So what might be interesting is to include behavioral determinants in the development of interventions related to return to work in cancer patient survivors. This might be a step forward for future interventions. Before going to the next part, things that we must not forget, maybe this is also a good time to see if there are questions about this part, what we don't know.
At this point, there are not any questions, no.
Okay,
oh, wait,
so then...
actually, just one said, what is the one intervention that did help with return to work back from the beginning of the session?
Okay, it is it's also nice to say that it's an intervention that was already developed in 1983. If I'm correct, it was a study by Maguire et al. And it was a nurse intervention. So I'm not exactly, I don't know all the details about the intervention, but it was a study of Maguire in 83. And it was a nurse intervention, I think, talking about return to work, supporting patients to return to work. So yeah, a nurse was involved in that intervention. And I think it was a multidisciplinary intervention, so also another specialist maybe or someone was involved.
All right. And then there was one more. Within social and health systems, who do you think has a role in developing this research and supporting individuals with return to work?
Oh, I think quite a lot of people. I think there was really a role for the occupational physician, also for the insurance physician. I think that was a role for the employer, because this is not the social and health system, but still the employer really has a big task, I think. We try a lot of the times to make the medical specialist more aware of the topic work, but they just have the time they have with a patient is so short that it's quite difficult to talk about a thing like work. So we know that a lot of nurse practitioners and also social workers are involved if it is about problems returning to work or staying at work. So here in the Netherlands we have a program that occupational physicians are trained to become a kind of consultants within oncology. So there are about, don't know exactly the number, but maybe about 20 or 30 occupational physicians in the Netherlands at the moment, specifically trained in oncology, and they are a kind of consultant also for other occupational physicians when they have problems with supporting cancer survivors to return to work. So that's also a group that really has to be involved in developing new interventions to support patients to return to work.
All right, and then there's been two more, but I think they're a little more broad and not necessarily right to this section. So you could probably go ahead with the next section, and then I'll ask those two after that.
Yes, at the end. Okay, great.
Okay.
So the final part of this webinar is about things that we must not forget. Because return to work is often the main outcome measure, but we also know that 62% of the patients already return to work within 1 year. So that's not bad. However, hardly any attention has been paid so far to those beyond return to work, because in a lot of times they get support to return to work and we don't know what happens to them after they return to work. So we do know that a significant proportion of those who are occupationally active again experience physical and psychosocial problems. For example, they still have fatigue, they still have a kind of anxiety, they are insecure about a diagnosis. Maybe it can come back again. Maybe they have still the pain issues. Menopausal complaints can persist for years. And also changes in cognitive functioning, because we know that a lot of people also that we have interviewed, were talking about cognitive changes, for example, and that they really notice that while working. So these complaints can persist for years after primary treatment ends. So what we did in 2014 was a systematic review on physical and psychosocial problems related to functioning at work in employees with a history of cancer after their return. So only patients who were back at work again were involved in this systematic review. And we found 20 quantitative studies because there is hardly any longitudinal research at this moment beyond return to work. So most of the time there are qualitative studies and some cross-sectional studies, but we found in the quantitative studies that physical problems such as poor health status, functional limitations, chronic conditions, lack of energy, nausea, hot flashes, the menopausal complaints, arm pain, motion limitations, that these problems influence workability in cancer patients after the return to work. Also, we found that psychosocial problems such as depression, fatigue, exhaustion, coping issues, and, as said, cognitive limitations affected workability. Next to these 20 quantitative studies, we also included 10 qualitative studies in this systematic review. And some quotes, for example, were, well, a breast cancer patient experiencing hot flashes, she said, I've deliberately got work where I'm working on my own a lot, and I can be shut away a lot of the time so people don't even see me. And with regard to fatigue, someone said, every 2 hours I was going somewhere to sit down and relax. I couldn't think well. I couldn't coordinate what was going on. So the point I would like to make here is that it's really important not only to support patients to return to work, but also beyond return to work to monitor them and to support them while at work. So next to this, I think it's also important, there's also a thing that we must not forget, is that a lot of the studies are within the first 2 years after diagnosis, and it's really relevant to assess how patients and survivors are doing at long-term follow-up. So now at this moment in the Netherlands, at the Netherlands Cancer Institute, we are doing the JOBS study, and this is up to 10 years after diagnosis, and this is specifically in breast cancer patients. And also my PhD student Peter van Meijen, he's doing the cohort study, and he's looking up to 4 years after diagnosis. So I think also with regard to the question that was asked, 5 years after diagnosis and the percentage of patients being able to go to work again, well, there are hardly any studies looking at that. So it's quite important to prolong follow-up and not only looking at the first year or the first 2 years. So that's quite important. And look also at the patients who are back at work again and monitor them and support them to stay at work and to prevent future sickness absence in these patients. That's quite important. So some final words about what we do and don't know, and this is also my final slide. So as said, there's a lot that we already know concerning cancer from work research. We have talked about occupational cancer, where it all began, cancer from work research. The shift towards occupational rehabilitation in the 1970s, it started with job discrimination, health insurance issues, then the broader scope of factors being involved in this kind of research. We know quite a lot of all the facts and the figures about cancer and work, all the factors that are associated with return to work, for example. And there are some interventions developed to support patients to return to work. However, I think that's still a lot that we don't know because there's only one intervention from 83 already that was effective. So we can ask ourselves, can return to work be seen as behavior? And if so, how can we integrate this in future interventions? So probably for now, the best advice is to keep calm and to go back to work. So this is my final slide. I would like to say thank you, and here are my contact details. So as said in the beginning, I'm in 2 locations, both at the VU University Medical Center and at the Netherlands Cancer Institute. So I've included both email addresses and phone numbers. And I think, Tonya, that we still have some time left for questions.
We do. It's technically right at time, but if you are okay with continuing on for another maybe 10 minutes and doing some questions, that would be
That's
great.
okay, Ami. Yeah,
Okay.
that's fine.
And those of you who can stay, please stay. We'll answer a few questions. Otherwise, you can also listen to them on the recording later if you need to go. Question. Have there been any studies on how involvement in religious communities impact the return to work process?
Not that I'm aware of, but I also have to say that I've not specifically looked for them, but I'm not aware of them. So sorry about that. I don't know it.
Okay. And then what types of things can an employer do to help increase the success of return to work of cancer patients?
There's quite a lot that the employer can do. I think that the employer really has an important task to do, because what we see in the beginning, and also a lot of patients are telling us this. Also the employers, because we also will involve employers in interviews and so on. But a thing that happens when a patient is giving the message to, or bringing the message to his or her supervisor, I've been diagnosed with cancer and what do we have to do? A lot of the time, an employer or a supervisor is saying, okay, go home, take your time, and we will talk to each other when it's in a few weeks or in a few months, when you are able or up to it. And that's totally okay, because this person is thinking, okay, I have to give him some room and to not press someone, so there shouldn't be any social pressure for you have to go back to work. And so a lot of the employees and the supervisors are really thinking that this is a good thing to do. However, what we know, and it's also from previous research, is that what we see is that how longer the period is when supervisor and employee are not talking and communicating with each other anymore, the more difficult it will be to return to work. And we see, and we also in the interview study that I did, a lot of patients were saying, well, I told my supervisor about it. He was very understanding. I went home, but I haven't spoken to him for 6, 7, 8 months, and then they find it more difficult to return to work. This is not always the case. There are also a lot of positive stories of patients who say, okay, but I really stay in touch with my supervisor. But we know that if the supervisor or the employer is able to stay in touch and to communicate and to talk about mutual expectations when to return to work, for example, that it's really helpful. So it's all about communication.
Very good. And then a somewhat similar but different, what can an employment counselor do to help the person return to work if they are not already attached to an employer?
Employment counselor. Well, what we have in the Netherlands, for example, there are quite some. I don't know if they have the same name abroad, but we call them reintegration agencies. So they're also a kind of counselors, um, external from the company someone is in, but they can help a patient to return to work. Also, the patients who don't have a job to return to. So things that they could do is to support them how to to write an application letter if they don't have a job, for example, or to talk about the thing that we were talking about. It's what was one of the questions, if patients should or shouldn't tell the diagnosis of physical limitations. So there are counselors who are really good in talking about this with a patient, so helping them to prepare for that specific conversation with a supervisor or a new supervisor. So that are things that a counselor can do. And we notice here in the Netherlands that there are a few reintegration agencies specifically skilled in helping cancer patients to return to work, and they are specifically doing these kind of things. So preparing patients to have certain conversations with the employer, also to stay in touch and to communicate. So it's not only a thing that the employer has to do, it's also a thing that the patient or the employee should do. So stay in touch with the employer.
Okay, I think that's all the questions we have. And oh, actually, I just got another one. I'll do it real quick. What if the manager you worked with is now gone when you return to work from being off for 2 years? What do you recommend for moving forward since the new manager might not be aware of the
Yeah.
past interaction?
This is a bit related to the question about what are you going to tell a new employer, because this is also a kind of new supervisor that you have at work, which is also kind of a personal thing. Some people chose to be open about it and just tell about diagnosis and physical limitations or cognitive problems, whatever, because they want to be open about it and just come straight forward to the new supervisor. Um, it really depends, I think, on the relationship someone has with the supervisor. Um, and if it's a new one, you have to build on a new relationship. So it can take some time to decide, okay, I'm going to explain what has happened to me. But it's a very personal decision to make. And some people say, okay, this is something that happened to me and I don't want to talk about it anymore. It's also a new step in my life. Regarding someone who started a new job, for example, but also at work. And if there's a new supervisor, you can decide not to talk about it anymore, and that's also okay.
All right, very good. So I think we're going to go ahead and end just because we are a little bit over time. And so thank you very much, Saskia, for the presentation. Super, super informative, and I really enjoyed it.
Okay, we